Today's episode of Vital Voices is brought to you in part by Oaktree Medical Center and Valor Security. Are you enjoying Vital Voices? Do you find our conversations educational, engaging, and inspiring? Then like, subscribe, and tap that notification bell to keep updated on new episodes and more. Welcome to another episode of Vital Voices, where we bring you expert insights on health, wellness, and the issues that matter most to you and your family.
Hold up! This week, the kids are taking over.
Wait, what?
Well, the kid doctors. This episode is all about us, kids. Ear infections, fevers, coughs, all the stuff that makes the parents freak out.
All right, since you're in charge, do you at least want to introduce our guests?
Oh yeah, we've got two super smart doctors here today. Dr. Sadé Lopez-King from the Princess Margaret Hospital and Pediatric Place, and Dr. Nadia Miller-Edgecombe from Princess Margaret Hospital, Healthy Kids, and Oaktree Medical Center. They're going to help us figure out when to worry about fevers, why ear infections hurt so much, and what to do when your cough sounds like a barking puppy.
Wow, that was a pretty solid intro. So, can I continue with the episode now?
Yeah. Go for it.
So, welcome both to the show.
Thank you for having us.
We are excited to have you guys on. Obviously, as a parent of a 7-year-old and an almost 7-year-old and almost 2-year-old, this is a topic and a conversation that's going to be very near and dear to my heart. And I'm pretty sure the same for our listeners who have young kids. This is going to be an interesting conversation. But I always like to give people, especially for first-time guests on the show, an opportunity, introduce yourself, give us a little bit of your background, like why you got into pediatrics. So we could get, just a little bit of a feel for who you are. So we can start with Dr. Miller-Edgecombe and then Dr. Lopez-King.
So, hi, I'm Dr. Miller-Edgecombe. Like you said, I am a pediatrician at the Princess Margaret Hospital, and I also work at Oaktree Urgent Care and also at Healthy Kids. I got into pediatrics, it was during my internship. So while I always knew I wanted to be a doctor, I never knew which specialty I wanted to go into. And so during internship, we get to rotate through all the specialties, and it was there that I thought that pediatrics was a better fit for me. So I did my pediatric training, started at PMH, entered the program where eventually I did go to Jamaica, where we had to complete our training. And so I'm here now.
Okay, awesome.
Okay, my name is Dr. Sadé Lopez-King, and thank you for that wonderful introduction. I always knew that I wanted to be a doctor. I'm not sure if I was jaded by the fact that my older sister also wanted to be a doctor, but very early on, I knew that that's where I wanted to go. I actually was considering obs and gynae first. I wanted to be the first person the baby sees, but med school quickly changed that. And I knew that pediatrics was a specialty for me. So after high school, a brief stint in COB, and then Dalhousie, and then on to Jamaica, where I completed my undergraduate, my MBBS degree. And following that, I entered the DM program at the University of the West Indies Mona campus. And since then, I've been now a practicing pediatrician.
Awesome. Glad to have you both here. So, like I said, the conversation we want to talk about today, obviously, this is relevant because we've had a host of respiratory issues and fevers and all kind of things in our kids in the local community in recent weeks and months. So, I guess we could start out at the beginning. Ear infections, fevers, coughs are among the most common concerns for parents, especially right now in this season. Why are these such frequent issues in kids, and what makes kids more susceptible to these conditions than adults?
All right, so I could answer that for you.
Mm-hmm.
So we know kids, they're still growing from what we can see physically, but the same way, they're also still developing their immune system. So everything is still very new, still very immature. And because of that, this in itself makes them more susceptible to infections. So they're being exposed to things for the first time. So of course, this is the first time their body has to react and respond versus you and I. We've had, all these illnesses throughout the year. So we better know how to respond to the illnesses. So that's why they appear to get sicker more often than, say, adults do, or older kids even. And then in addition to that, so in terms of fevers, because just as the child is immature and their immune system is immature, they produce more of something called pyrogenes.
Okay.
And basically what this does is causes a more exaggerated response to an illness and produces fever. So that is why when kids are exposed to things, because they have more pyrogenes, then we see these fevers coming about, as opposed to you and I when we get sick.
All right. I mean, I always thought it's just because like kids just don't know how to keep their hands to themselves. It's like always hands in this and on this, and then in the mouth and in the nose and in the ear.
And that's part of it too, yes.
Of course, too, they also have, anatomically, they are a little bit different. They're not just tiny adults. Mm-hmm. They're almost their own entity.
Right.
And, pediatrics is one of those specialties where a neonate is different from a toddler, is different from a teenager.
Right.
So, yes, they're all humans, but as their anatomy changes and they grow, you find that also in and of itself may predispose them to more infections.
Okay. That's interesting. Let's dive into the ear infection space first. How, because I imagine for a lot of parents, a lot of these questions kind of stem around, like, how do I know when to go from trying to manage this at home to seeking help? How do I know if this is just, so like with the ear infections, how do you recognize the difference between something that's just general ear discomfort and when it might be turning into, or if it's already an ear infection?
Okay. First of all, you know your child. So if I could give a story, I have two rambunctious, wonderful children, a 7-year-old and then a 3-year-old. And I remember one day my daughter, she was younger, and she just walked up to us. We were in the room just chilling, and she just held the air and she screamed. Not like tugging, playing, but screamed.
Oh, wow.
So off the bat, I knew ear infection.
Right.
So when you see your child is screaming in pain, it is most likely an ear infection as opposed to discomfort.
Right.
And then too, just looking at the whole picture. So things, and I know that can predispose their infection would be like a cold. So say for instance, your child had this runny nose, they had this cough, they had a fever, and now they're complaining, Mommy, my ear hurts. Daddy, my ear hurts. Most likely it could be an ear infection.
Right, because you have one thing building on
Correct.
top of something that was already there.
Correct. Stuff like if, they went to the beach yesterday and, was under the water a lot swimming. So looking at the whole picture. And then when it comes to discomfort, you might find they might just be like tugging at the air per se, but not really that holding, screaming in pain.
Right.
And then if they are able to tell you, like describe the pain, they might say, it just pops or it feels funny. That in itself is more of a discomfort than the pain associated with the ear infection. Right.
Because I guess like you said earlier, the thing is it's going to be different from kid to kid depending on the age range, because it's like, if you have a 1-year-old, they're not going to be able to say my ear's hurting. It might be that pulling and screaming versus, a 7-8-year-old who might be able to articulate, hey, my ear is funny, like it's doing something funny. It feels weird. It feels different.
Which is pretty much why, sometimes the younger the child is, they get a more extensive examination. Their complaints may be non-specific. A vomiting and diarrhea might turn out to be an ear infection. When you delve a little bit deeper, you find that that's your source in a very young child, as opposed to like a 7-year-old that can say, Mom, my ear is hurting.
Right.
And might not present the same way. So when they come, especially when they have those high fevers, which is going to be one of those things too that helps you to differentiate between ear discomfort and infection, and they have those fevers, and we look at them, we're like, okay, I'm going to do, to check everything, ears, nose, throat, to look for our sources, especially our common places, of which those are. Right.
So, I think you mentioned this a little bit, the going to the beach, like being underwater, having had a cough or a cold, things like that. What are some of the other causes of ear infections in younger children? And are there some kids who are more prone than others?
So I'm going to put in my little plug about breastfeeding here.
Okay.
because as a pediatrician, breast is best. But believe it or not, breastfeeding in itself is protective against ear infections. So you would find that kids that are exclusively breastfed, they tend to have less ear infections as opposed to kids that are bottle fed.
Interesting.
Right. And there's a science behind it. So if you think about it, when we are breastfeeding our babies, we tend to hold them upright. Now, as Dr. Lopez shared, they're not quite tiny adults. So they're still growing. And a part of that is the eustachian tube. So that's this little tube that connects the back of the throat to the air. In adults, it's sort of slanted, if you think about a slide, which is good because this way it prevents anything that's in the back of the throat from getting to the air. Now, in our young kids, the way it is, it's sort of horizontal.
Everything is more compact in there.
It's very compact, so it's very easy for fluid to go from the back of the throat to the air because of the way the eustachian tube is now positioned. So because of that, if we're nursing and our child is upright, that in itself prevents, well, not prevents, but sort of helps to prevent that backflow of the fluid. Versus a lot of times, we'd give the child a bottle and lay him down on the bed. So he's lying flat, she's lying flat, and this bottle's just there. And so we have this liquid pooling, which could then predispose them to these air infections.
Oh, wow. Never knew that.
Additionally, you have kids that have eustachian tube. We talk about this eustachian tube a lot because that's going to be a part of your physiology of ear infections. And so if those are blocked, if those are swollen, if kids who have recurrent tonsillitis and swollen tonsils because of throat infections or whatever the case may be, they are going to be an increased risk too for the same reason. You also have those kids that have predisposition or an increased chance of getting ear infections just because of their anatomy, like I had mentioned earlier. So kids that might have Down syndrome, or some kids with cleft palate because of how the structure of their faces or the bony structure of their face and the eustachian tube alignment that causes them to have increased risk. But even going back to the breastfeeding, because we can't help ourselves, breastfeeding has that increased amount of antibodies, and a particular antibody called IgA.
Yes.
When we say breast milk is the best milk, breast milk is liquid gold, it is literally that thing. You'll find 9 times out of 10 you show up to the pediatrician office and your complaint is vomiting, did you breastfeed? The complaint is constipation, did you breastfeed? The complaint is, whatever the complaint is, eczema, did you breastfeed? And so, there's a science behind that too. If mommy can breastfeed better than giving cow's milk, so there's some theories behind that as well. But even going back to the antibodies, that particular antibody that's abundant in breast milk actually lines the surface of your nasal pathway and certain places inside of your throat. And what that does is those antibodies are soldiers. So when they come in contact with the bugs that cause infections, the soldiers are there, you're not getting in. And so if you have a constant supply of that, what we call passive immunity that comes from breastfeeding, the baby's not making those antibodies, they're getting it from mommy, that's what makes it passive. They're getting a constant supply. Now you have your soldiers ready.
Yeah, they're ready to go to war. So like I said, I think a big part of the parental question when it comes to stuff like this is, okay, so how would a parent know when it's okay to treat like an ear infection at home versus like what is that threshold when it's like, okay, now you really need to come in and see whether that's like a pediatrician in an urgent care center or even as far as going to the ER?
So for instance, if you have a child that's 2 months and under, if you're suspecting, so if that child has fever,
that threshold is very low.
There is no threshold. You just come right away. So 2 months and under, definitely straight to see your pediatrician. So now when we get to that age of 3 months to about 6 months, how do I put it? If you are having what we call high fevers, so greater than 102, If your child is looking unwell and you know your child, so that's not a child where you want to sit and watch. You would want to see a pediatrician. Now, if you have a child that has fever, but you'd be like, doc, they're still feeding well, still acting like themselves, that's something where you may watch for like 2 to 3 days. But if you're seeing those persistent fevers, once again, see your pediatrician.
High irritability, pus or fluid draining from the air, definitely.
Yeah, we don't watch those.
Yeah. So, I guess once you get into the point of where you have to come in for your kid to be seen. I know we culturally, and I don't even think this is just applicable to us, there's an expectation a lot of times, like and I think I've said this on the podcast before, like there was just augmentin in our house, right? As a kid. Sorry, I'm just saying, like, and I'm not the only one, so I'm not going to say that. I'm not going to say that shamefully, because again, this is the culture that we live in, right? But sometimes parents will come in with the expectation of, okay, it's just going to be antibiotics.
Yes.
What kind of drives that decision? If it's necessary or not. I think we talked about the part about watchful waiting, but like, how do you know the difference, and how do you help parents navigate that?
So if you come to the doctor and it's deemed that your child has an ear infection, children under the age of 6 months, we don't watch and wait. They get treated. Mm-hmm. They get antibiotics.
This is too risky, right?
Right, because their risk of complications is higher. Children that are between 6 months to 2 years, you can do the watchful waiting. This is a well child, usually a unilateral one-sided ear infection. They don't have severe symptoms. The fevers aren't very, very high. They're not extremely irritable. They're not lethargic. These are your patients with milder symptoms. Any child really that presents severely, pus coming out the air, high fevers, extreme irritability, those ones are more likely as well to get antibiotics.
Now for anybody familiar with our show, one of the things we love to talk about is how do you do prevention, right? Because a part of it is, I imagine a lot of parents, I don't want to have to take my kid to, urgent care or the emergency room or the doctor. So what are some ways to prevent or to reduce the risk of ear infections? And obviously, breastfeeding is good up to a certain age, but for your 10-year-old, what are your prevention strategies?
It's not gonna hurt him.
Whose breast are you getting that milk from?
Yeah, I'm just gonna say no. So ways you could prevent. Starting simple, hand washing. I know it sounds simple, but hand washing.
Nasty little buggers.
Honestly, they touch everything.
They do.
Yeah. Touch and put back in the mouth. So hand washing, stuff like when you do go swimming, when you wash your hair, simple as just draining the excess fluid out of the air. It goes a long way and it helps. Believe it or not, pacifiers can actually help and prevent. Now, I'm not a 10-year-old.
Right.
But in your infant, pacifiers have been proven to help prevent ear infection. So it goes back to that whole eustachian tube dysfunction. So if you can imagine, when you go on the airplane, you get that popping sound. Someone else say like chew gum or drink something or swallow. So it's almost the same thing.
It's
so
like
that
when you come off the plane. Yeah.
So that sucking reflects the pacifier, just helps to keep the eustachian tube nice and
clear.
Open and clear.
And additionally, reducing smoke exposure. So, so smoking, people like to say, I smoked, but I smoke outside on the patio, and then I came inside to the kid. But all of those allergens, those harmful substances that are coming from the smoke, they're on your hair, they're on your clothes, you got to brush your teeth, you got to bathe, wash your hair before you interact with your child. It's just best not to not smoke. And additionally, avoiding bottle feeding while laying flat. I mean, of course, we want the breast milk, but if you have to bottle feed, you bottle feed in that semi-reclined position to help with the fact that how their anatomy is shaped. And of course, shameless plug for vaccinations. Vaccinate your kids. They have been shown to help prevent some of the more common causes of ear infections.
All right. A lot of good information there. So let's move into fevers, which is another interesting one. I know, again, having young kids, it's always that conversation of, like what is actually a fever, like what actually happens in a child's body when they have a fever, and is it always a bad thing?
So fever is anything 100.4 if you use Fahrenheit and 38 if you use Celsius. So it's just a higher than normal body temperature. Is fever a bad thing? No. It means your immune system is working. Of course, we know it's disheartening because being a parent, for whatever reason, a fever comes on and your child's energy, it just
everything craters.
Dwindles. Correct. So no one likes to see their child in distress. We like when they're up and they're happy, so I get it. But to be honest, when we have what we call low-grade temperatures, so like your 100.4, 100.8, so nothing where it's like 102 and above, a lot of times you don't necessarily have to treat those fevers because it's your body's natural response to fighting whatever infection is going on.
Yeah. See, this is where I always be happy that I have a wife who's a physician, because if it was me, like, because in my mind, normal body temperature is 98.6. And so it's like, if the kid is sitting at 99.6, I'm like, okay, something has to be done, right? Because that's just kind of the way you think about it. So I'm always grateful. She's like, well, you got to watch it a little bit while longer. And then I know, like sometimes we'll do like sponge baths and things
correct,
like that.
Yes.
But you mentioned 100.4. Like, is that the temperature which you should worry, or is it like beyond that?
So 100.4 is the start of a fever, right?
See, that is still confused me, because if the normal temperature is 98.6, how are you hold to 2 degrees higher?
So I say it's elevated, right? It's not normal,
correct,
right? But it's elevated. Something is happening.
But you got to explain it for the layman, right? Because it's like you thinking about it. Again, when you're talking about parents with young kids, it's like you trying to navigate how you're supposed to think about it.
It's like you're boiling the water. So, you have to get to a certain temperature for the water to actually bubble.
So it's like the rolling boil.
Exactly.
Okay.
So like in the process, the water starts off cold and, we're slow.
Yeah, the slight bubble.
We're getting there.
I got you.
So
fair enough.
And we don't always reach to the scary numbers.
Correct.
Right? And sometimes, like you said, a sponge bath, which is room temperature water, not cold.
Yeah, I know.
Because I've seen people give ice baths to children. That's actually counterintuitive, because the shivering that occurs afterwards can cause you to... It'll raise your body temperature. Your body's trying to heat up.
Yeah.
So now you end up with a hotter baby than you started with. So a tepid water bath and then light clothing sometimes is enough to keep things at bay.
A little singlet and like even in underwear.
I mean, do you have the AC on or off in that circumstance?
It honestly doesn't.
See, because I like AC, right? So it's like I have to think about this from my selfish perspective.
Keep the room comfortable.
Yes.
Let's put it that way. Because a very, very cold AC is going to do the same
not
thing.
for me. For them.
Correct.
For them, yes.
Okay.
Cold AC going to do the same thing as ice cubes.
Right.
If it's too cold, they'll shiver.
It's the same idea, right?
Exactly.
Okay, so are there specific signs when a kid has a fever that is a clear indication that this is now an emergency?
So once again, age. Remember that 2 months and under? No watching.
Oh, no.
Even if it's 100.4, emergency.
Emergency.
There's just too much things at risk at that point.
And the risk for complications is too high.
Yeah.
So definitely that. And then anything associated with it. So you become emergent when you get into stuff like a seizure that can occur with your fever, right? Which is a big topic in and of itself.
Yeah.
But those kids definitely should be seen.
Right.
We need to evaluate what's causing the fever and give advice on how to keep the fevers from rising high again to prevent those seizures from occurring.
Right.
Additionally, if the fever is accompanied by a child that is lethargic, not eating, severely dehydrated, ill appearing to you, or I also tell parents, it might not be emergent, but if the parent is concerned, a concerned parent is enough for a child to be seen. Yeah. Sometimes it's just that mommy's clinical suspicion. Yes. We have neonates that their presenting complaint is meningitis. I mean, their presenting complaint, is irritability. And it turns out they have a meningitis, never mounted a fever.
Right.
Yeah. So we take into great consideration how the
maternal instinct,
and paternal.
Yeah. Well,
we don't just daddies.
Fair enough. You mentioned febrile seizures, which is obviously very scary for parents. what information can you give for parents to know, like, if that happens, what should you know? How do you respond? What's the best way to manage that in the moment, right? Because obviously, I imagine you don't move the kid in the middle of a seizure, other than trying to get them situated appropriately, side, yeah. Right? But like, what do they do in the moment and up until it's time to like, okay, get them in the car, get them to the hospital or the emergency room?
Okay, so a febrile seizure, as Dr. Lopez stated, can be one of those complications of a fever in our pediatric population. But just note that if you have a 4-monther who has fever and a seizure, that's not a febrile seizure. So it's age dependent.
Okay.
So it's generally between 6 months and 6 years of age. So anything outside of that, you should see a physician. That's not a febrile seizure.
Right. Fever or not.
Fever or not. So febrile seizures are generally benign. So I know it's scary. Personal experience. And if I could put in a plug, my son was sick. And my husband kept saying he feels hot. And I'm there like, oh, he's fine. Because he was still running around playing. My husband was like, no, he feels hot. And I'm just like, oh, you worrying too much. Lo and behold, my son started seizing. And if looks could have killed, anyone who knows my husband knows. Yeah. Don't play with his children. So scary. But what do you want to do? First, as hard as it is, try not to panic. As best as possible, try to time it.
Yes.
And I know it's hard in that moment because you're freaking out, you're frantic, but just look at the clock. Yeah. And I say that because the timing for that is very important. If you see it's lasting more than 5 minutes, straight away to the hospital because it's less likely to stop on its own at that point.
Obviously, we talked a little bit about sponge baths as a home remedy. What are some other ways that you can safely manage a fever at home? And, when should, we need to go to the hospital? How do you know, what type of at-home medication to use? Like, if you're using acetaminophen or ibuprofen, how do you help the parent navigate that decision if they're at home with a kid who has a fever?
Oh, I just want to...
Oh, go ahead.
One more thing about the febrile seizures, which is seizures that occur secondary to fevers, right? For people who may not know what that is, do not put anything in their mouth. No spoon in the mouth. Don't blow in their mole. You turn them on their side. You're calm. You time it, and you should seek medical attention after your child or anybody has a seizure. So that's definitely something there. Don't put anything in their mouth. Remember that they don't have control over their body during that time. So something that goes into their mouth, liquids, that could go down into their lungs, right? And so now we end up with a bigger problem. A febrile seizure is something that usually does not cause any significant brain injury. Those kids bounce back. You see them running around the emergency room after a dose of ibuprofen, and they're happy. And the person who put in some ice, cold water into his mouth to cool him down, and now you end up with an aspiration or some fluid down the lungs. We have another problem we're treating. So don't put anything in their mouth. Time it. Get to the hospital. And then when it comes to, in terms of prevention of febrile seizures, when it comes to the home remedies, prevention is key. You can't stop a seizure after it already occurred, but what you can do is stop the fever or break the fever.
Right.
So a lot of parents like to touch, we call that subjective fever. Mommy says baby is hot, and we do take that into consideration. But own a thermometer. Own a thermometer and be knowledgeable. That's why it's so important to see a pediatrician, to be knowledgeable about what constitutes a fever and what is significant for each age group. Additionally, keeping the medication on hand, and I cannot say this enough, Cetamol, Tylenol, Paramol, Aramol, acetaminophen, that's the only one that don't match. All of those are the same drug, right? So I've seen parents, I gave Cetamol and I gave Calpol. I gave Cetamol and I gave Tylenol. And those are the same thing. And so now you end up in a space where you could have overdosed. Right. And of course, your acetaminophen, paracetamol, and the alls are all the same group. And ibuprofen is its own different type of drug, but it's not, you can't use it for certain age groups.
Right.
Correct.
So we don't want you to get to a place where you're misusing the first line, the thing that you could use most for all of the age bracket.
Right, that's the first line of defense. Yeah, it's interesting. I know we have like the baby this and the children's that, and we have like, I think we have children's Motrin and baby Motrin, and we have children's, I think, Panadol, Tylenol, and baby. So, and that's the thing. And it's like, we try to make it a point, because obviously those things expire. So you check and you make sure that it's current every so often, because you don't necessarily have need of it every day, but you want to make sure if you end up in a situation where you need it, what you have is actually like not expired and it's proper and that sort of thing. It's interesting. The spoon in the mouth thing really like shook me, because I grew up like with that as a thing that they would tell people, like, you do that. That's crazy work to me, because that's the first time I've heard that. Right. And obviously, like we've been blessed to not have had, but at the same time, that's crazy.
I literally saw a person in my COB days have a seizure in Wendy's. That's where you have to eat at COB. Yeah. And they turned her to her side and shoved the spoon down her throat. They just put it right in there.
A plastic Wendy's spoon?
And she was chomping on it because, she doesn't
because you don't have control.
Exactly. And, in my brain, I'm like, well, that doesn't sound like that's a good idea. But because of your lack of knowledge, nobody stops them. When the ambulance came, they took it out.
And the Bible says, for lack of knowledge, the people perish, right?
For sure.
And then, if I could just add, a lot of times parents would give that one dose of the Calpol, and then they'll come like, oh, doc, it stopped working. Just a reminder, it only works for a certain amount of hours. So I always preach to parents, if your child has an ear infection, they have a little cold, there's a reason for the fever, and it all takes time to go away. So you want to give it around the clock. So if it is you're giving any of the alls, that's what I call them, those last 4 to 6 hours. Right. So around the clock. But I know oftentimes you would have patients where that 4-hour mark, boom, you just know they do for the medicine. It's them where if they're old enough, so older than 6 months, you can give the ibuprofen or the Motrin to try and help stretch it. Right. So we'll call it like rotating it that way. But just to bear in mind, you want to give it consistently around the clock. Yeah.
Especially
to break that cycle.
Kids.
Right.
You don't want them to spike a fever.
Right.
You don't want to wait for the fever.
So that's the thing. If a kid has a febrile seizure once, does it make them more prone to having it?
No, it doesn't.
But the family, there's a familial predisposition. Right. So if you have a parent that has febrile seizures, the child is more likely to have febrile seizures. And additionally,
so you're at risk.
So you're at risk. And I mean, but how do you remember, right? You were 5 years old. So usually the Grammy will say, well, you had that when you had a fever. And then that's when you cue in. But just one thing to remember about the febrile seizures, because it is one of the more scary presentations. If the child is not, these are children that are neurologically normal. Their neurological exam is what we call normal, right? So a child that has injury to the brain, a child that has cerebral palsy, children that have some type of pathology, they do not have febrile seizures. Correct. Right? We don't call it febrile seizures.
Right, because at that point, there's something else that's driving the seizure.
That predisposes them to having seizures more frequently, right? So we'll say the fever does lower the seizure threshold, right? And so if this is a child, even if this is a child their exam is normal, but they are known to have seizure disorder, right? Or epilepsy, they also cannot have that's not a febrile seizure.
Correct.
Fair enough. Any misconceptions about fevers that parents should I guess stop worrying about?
The first misconception is that you don't need a thermometer. I've seen a lot of people. No, seriously.
That sounds personal.
They do the hand on the back, and as soon as I say, "What was the temperature?" and I see them raise their hand, I say, "Okay, I know where we're going."
Listen, we didn't have one in our house. Fever was mommy come and put out the back of hand on your forehead, on the neck. On the back of your neck, that's what it was.
And that's perfectly fine. If it feels hot, check it. That's what I usually tell them. Don't stop your process.
Take it a step further.
Just give me one more so I can write something down and manage differently. And then there is this. It is.
I have to laugh because my husband is like that. So he'll be like, "Oh, so and so has a fever," and I'll be like, "Okay, what's the number?" I don't need no thermometer. They hot. And I'm just like,
He was burning up dog, temperature 99.
I appreciate that fact.
But here's the
just
thing.
shocking.
So, but I appreciate that because for me, and I feel like, you know, I obviously would start with that, right? Because like you holding the kid, and you're like, well, this kid feels kind of hot. Like, so like, especially for our 2-year-old, because that's more current in terms of your fear factor is a little higher, right? So I'll be holding out. She'll be like, boy, you feel hot, you know? And do the, because you start there because that's just cultural, right?
Correct.
But the thermometers helped me a lot from freaking all the way out because then you take the temperature and dude is like 98.9. I'm like, okay, so clearly either you've been running around
or my hand's cold.
Right. Or I'm cold and therefore my perception is different, right?
Correct.
Which is why that's not the best way. It's fine to start there, like I said, but it's not, we need something more objective. And then another misconception is that high fevers always have to damage the baby's brain or the child's brain. It does not mean the fever, remember, is a body's natural response most times.
This is fighting something.
Yeah, it's fighting something. I mean, when you out to war, you're not chilling laying down. You know, when you out to war, you out to war, your adrenaline pumping, your body is in fight mode. And so that is it's telling me that your body is doing something to combat whatever is happening.
Right.
Okay, so it's not always that fevers are, we don't want it to be scary. We want you to be educated.
Correct.
And know what are scary numbers, what are scary ages. And of course, always things are clinical. I don't care if the temperature is 99. If the child looks ill to you, toxic, not moving, lethargic, dehydrated, he needs or she needs to be seen.
Yeah, I think it's, and I've heard a lot of physicians. So it's like you know the kid, know the patient, know yourself, know what looks and feels normal, and then have the threshold be based on that in as much as it is the number, because you know it could be a 99, but if they knocked out, can't move, can't function, that means something now has to be done, right? So let's move into our final area, which is coughs and respiratory infections, which in a post-COVID world is, it's a heavy one, right? Because obviously nowadays everything is, I feel like everything in that space is a lot more heightened. And then obviously we had a run of a lot of kids having respiratory issues in the past few months. But you know, when you start to look at like that, like the cough side of it, you know, because we know you out in public, especially if you have kids, and you hear somebody else coughing, it's like, okay, so we leave it? Because this feel like we leave it. But what are some of the different types of coughs? You know, people say, oh, it's a dry cough, it's a wet cough, it's a barking cough, it's a wheezing cough. And what do they indicate based on the different types of coughs that exist?
So you are correct. There are different types of coughs. So when you have your dry cough, typically you might see that in patients who have asthma. So believe it or not all asthmatics wheeze. Sometimes it could just be this very persistent cough, and that's how that particular asthmatic presents. When you have a wet cough, sometimes it could just be from all the mucus production buildup. So it might mean, but doesn't always mean, a child has a pneumonia. It could just be due to the mucus buildup. And then what we call that barking cough. So if you could imagine a seal,
Yeah.
I promise you, once you hear it, you won't forget it. They literally sound like a seal.
And it sounds different. You'll be like, this one, dog? They say, this one sound different. So,
that one is usually associated with something called croup, which is another viral illness. And of course, your wheezing cough that I can't.
So
of course, you know what that one is.
What's so funny is, you know, you don't really say much about a wheezing cough often, but I went to Jamaica and I got sick, and every 2 seconds, there's a wheezy cough. Every 2 seconds, and I'm like, maybe I'm wheezing. And I, you know, like the people listening, like, you're wheezing, you need to take meds. And I'm like, I think that kind of cued me in more to what is the intricacies of a wheezy cough. Parents will come and say that kids are wheezing all the time, and I will say, not 9 times out of 10, 8 times out of 10, the sound that they're describing is not a wheeze, even though the child might be wheezing. So this is a mom who knows their child wheezes. The child has asthma. The child has wheezes with respiratory illnesses. And the mommy say, oh, he's making a sound. The sound you're hearing what I'm hearing is not a wheeze until I auscultate. And I'm like, okay, no, this is a wheeze. But there are certain coughs that sound like a very wheezy cough, but the cough itself doesn't necessarily sound like what I auscultate when I hear a wheeze. Not all the time, I should say. And when parents do have when children have an audible wheeze, which is the same sound that I hear when I auscultate, I hear it on the outside before I auscultate, then we know we're in.
The wheeze is almost like it's a struggle to breathe as you cough,
That's what it is.
Yeah.
Literally, it's so that obstructive sound.
Is the wheezing cough the only one that's associated with asthma? Or is it like a bronchial cough as well?
The dry cough.
We were at
the dry cough, and if they have a pneumonia on top too, they can have a wet cough.
We were at a function a few weeks ago, and there was a bouncing castle and a ball pit. I'm grateful for having a wife who's a physician. So there was this one kid who the cough was just like coughing, and I looked at her and I'm like, "We taking a turn and we leaving?" And she was like, "But it's only on activity." So it seems like it might be like an asthmatic cough.
Correct.
So and that's the thing. When the kids stop running around,
the coughing stopped.
And then when they started running around again, it was like, okay, we really need to go because it's coughing, right? But it is things like that too, because again, you go into a very protective mode as a parent. And so even just to know that, okay, if you see that the kid, again, because you're at functions, you're going to be in things like this. If you see a kid who is really only coughing on activity, then you can feel a little bit comfortable, like, okay, my kid's not going to come home with COVID.
Correct.
And then, of course, the one that you don't hear as much, because shameless plugs for vaccines, but pertussis, right? So that whooping cough, that cough, 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 cough. And that sound would be called a whoop, but that's more inspiration, breathing in, as opposed to the wheezing, which is more expiration. When they exhale, you hear that whistling sound. But, you don't see it as much because patients, most people are vaccinated. So you don't see it as much.
And then
why though?
On a less scary note too, some persons might not realize, but sometimes reflux can cause a dry, persistent cough.
Post-nasal drip.
There are a host of reasons.
Yes, chronic cough.
Yeah, so you would find patients have runny nose, and it'll be like at night, doc, the coughing just won't stop.
Yes.
Those post-nasal, your child love the Takis. That's the name. The Takis, and they love a lot of hot sauce, and all the bad stuff.
Boy.
It could just be reflux, but if it's that persistent dry cough.
I've definitely had personal experience with a reflux. It's funny because me and my wife were just talking about this recently. Like back when I was really, really bad in my eating habits, like you have bamboo at like midnight with extra hot sauce and ketchup. And then you roll over at 2-3 a.m. and you're like, what the hell is happening to my body? Yeah.
And it's sitting up high.
Yeah.
One wet burp and you taste all your bamboo. Not fun.
All right. Let's get back on topic. So how do parents tell if a cough is like associated with a mild cold, or if it's something that may be more serious like a pneumonia or bronchitis? Like, what's that spectrum?
So one, everything like we said in perspective. So you would have, like I said, I can speak about the reflux because I have it. So sometimes I always have this little, she's nodding because she's just like, yup. So I'll have like this persistent dry cough, but I know my eating habits. But say for instance, you have this child, it's that, we call it that wet hacking cough. And sometimes they're complaining about chest pain when they cough. So that's different. That can sometimes be a sign, sometimes it could just be inflammation.
Right.
And sometimes it could be signs of pneumonia. Like we say, fever. Right? Fever, they're unwell, sometimes vomiting, just lying around. You'd be like, doc, they normally be running around playing and they just in that bed, not moving. So,
and we also have a little, not to interrupt you, sorry, a little triad that we use in medicine: fever, cough, and tachypnea, which is breathing fast. So you look at the child. I mean, the average person will not know what is a normal breathing rate. But when you look at them and they are, you see that they're breathing really fast, they got a fever and they're coughing a lot. That's usually our triad to indicate that a pneumonia might be looming. Something else going on, especially when you see signs of distress. So a cough, an intermittent cough in a child that has a cold or apparent viral symptoms, they're well, they have low-grade fevers. The cough, even if it started off dry and became wet, there's no distress. Sometimes we watch those kids. We usually educate parents that if you see the nose starts to flare, they have sinking in at their neck, if you see the ribs become very, very apparent when they're breathing or they're breathing very, very fast, you need to bring them in because respiratory distress is not a very good sign, right? So, and that tells us pneumonia. And also, I thought pneumonia was like the be all end all. If you got a pneumonia as a child, I thought you got a pneumonia, like that is your grave. And it's like people have pneumonias all the time and they don't know. Viral pneumonias that do not require antibiotics, pneumonias that are just require some outpatient treatment, so not all need to be admitted. We generally would admit for severe, like low oxygen, severe distress, signs of significant respiratory compromise. Those kids and people would likely be admitted.
Shameless plug from my perspective, and being a parent, having a pulse oximeter at home is, you can tell me if I'm wrong, but I feel like it's a recommendation because when you mention oxygen levels, obviously you're saying you can see it, but we have one right at home because again, between me, my wife, and the two kids, you just feel like you just have all the little things that you need.
So, if I may add, I am against pulse oxes. When I hear parents say they have pulse ox at home, I'm just like, why are you putting yourself through that mental torture?
Well, that's what the book says, right? It says it can increase the risk of anxiety.
Yes.
Parents that can't sleep at night. Sometimes patients do have mild dips in their oxygen saturations when they sleep.
And I think that's what's important.
And they get scared.
You can dip.
However,
come back up.
We don't use it in the sleep. Like that's like me just trying to see in the moment.
We're not talking 80s. We're talking like very, very mild dips. Now, normally it's 95 to 100. And I mean, I understand as an anxious person though, I'm not against this. That's what the book said.
Yeah.
How do I put it? From what I understand you're describing, I want to say that's okay. So if your child's an asthmatic, and you just want to be like, you just want to see what the oxygen is, I'd be like, okay. Yeah. Right. But then we have some parents who will put it on at night while a child is sleeping and they're up. And I'm just like, you shouldn't do that.
No. I can't do that because then the anxiety go way too far.
Right.
It's been more so in the space of an in the moment just to kind of see.
Like a spot check.
Right, because what you're trying to do is get an idea of where are we in the spectrum and do we have like an issue that requires us to like take the kid in. Right? Okay. And so it's more of like a one-off. It's that's crazy work.
You have parents that do it. I'm just
we had like the baby toe one.
See?
The owlet. Yeah, so we had the owlet when my daughter was young. But even that, like we had so much issues getting it to stay on properly. Like that never was really a long-term thing. Right? And again, that probably wouldn't have worked well with the anxiety. This cough syrup question is an interesting one. So I didn't notice until we were like researching this and putting together, I don't think our kids haven't really had a lot of coughs over the years. So I found out in the process of doing this that there's some issues with over-the-counter cough syrups when it comes to young kids, especially. So why is that? And what are the alternatives? Because, we like to jump to treatment because we don't want to bring the churn into, nowhere.
Nobody, you don't want to have them in the office and they're sick and they're around sick children. So cough medicine for kids under the age of 6 actually isn't recommended. There are numerous concerns. One, intermittent coughs that are not associated with distress and low oxygen and child is fine. it's a natural reflex. We're not talking about those coughs that are preventing the child from sleeping, the children that are vomiting consistently because the cough is stimulating their gag reflex. We're talking about kids that are relatively okay and the cough is improving as the illness course progresses. They don't need anything, especially if they're under the age of 6. There haven't been much studies to show that it's the efficacy of, or they've been proven that there is efficiency in giving kids over-the-counter cough medicine under the age of 6. So I have a lot of people come, I want Bisolven, and I want
Dawa cough.
Yeah. Bisolven is a big one. I feel like that's the most common one, and that they ask for, but they would have already tried things like Histal and Robitussin over the counter already. But even Bisolven in of itself is for a certain type of cough. The type of cough medicine depends on the type of cough. So it's not like a be-all for any type of cough as well. And then, of course, the cough medicine, we like to say it treats the parent. So the kid gets sleepy and they cough less because they're drowsy, which is one of the risks because you can overdose and you can have serious sedation from these. And then certain cough medications include other medications with it that can cause elevations in heart rate and blood pressure. So if you have kids that are...
And the kid might not even need that.
They might not even need it, exactly. So if you have kids, we have kids that have hypertension for numerous reasons, right? And kids that have abnormalities with their heart that cause it to beat faster. And sometimes you might not even know that your kid is predisposed until they get on a medication that causes them to have, a fast heart rate. So we generally recommend against the medications that contain those ones that, even Cetamol will have it as well. So medications are going to increase your heart rate and blood pressure. So definitely, it treats the parents, but it's not necessarily helping the kids.
Just piggybacking on what Dr. Lopez said, different cough with different medicines. So if it is what you're describing to me, when you come into the office, sounds like a post-nasal drip. For that, we might prescribe an antihistamine to basically help to dry up those secretions and help the child to sleep better at night. That's your Zyrtec. And I think sometimes what parents should take note of, the child can have an illness and, went through the fever, the wet cough, but then it'd be like the cough is now dry and it's just lingering. It's normal. So cough is sometimes the very last thing to go. And I'll tell parents, you'll find the child looks better. They're eating, they're up.
And they're still coughing.
And they're still coughing. Eventually, on its own, it will go away. And just to piggyback why we don't like the over-the-counter cough medicine in our younger population, you want them to cough. It's a natural reflex, so there's a lot of gunk going down. And sometimes you'll notice they'll cough, 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 and then they'll vomit all this mucus up. Right? When we stop that cough reflex, we're sort of keeping it down because you and I, we keeping it in.
And you want them to clear the secretion.
Right.
Yeah.
Which is difficult in smaller kids.
Yeah,
correct.
I remember the first time my wife explained to me the difference between cough suppressant and expectorant.
Yeah.
Yes.
And I was like, oh shoot, I didn't even know. Like, that was news to me. And a realization of like, oh, right. So you might not want to suppress the cough if you like on the verge of pneumonia and stuff like that, because then you just, everything is pooling down and they're doing all kind of funky stuff.
Correct.
So yeah, I think it's things like that too that people need to understand, like the difference between even the types of things that exist out there, because you might not want to suppress it, and sometimes you might not even want to expect it, and you just want the child to kind of go through the process as naturally as possible. Obviously, again, we're in a time post-COVID, we had things like RSV pop off immediately after the pandemic. And obviously the flu and all of its variants that happen, bird flu, this flu, that flu, next flu. How do those common viruses contribute to severe coughs and breathing issues?
So if we talk about RSV and flu, we find that these viruses are actually more harmful in our extreme of ages. So your babies. So in particular, RSV could be a really nasty bug in terms of babies. So if you read, it's actually recommended that all babies, before a time it used to be babies that were premature, But because of the benefits that they see with giving the RSV vaccine, it's actually recommended that all babies that are born during that RSV season, which is usually between October to March, sort of where we are right now, they actually should get the RSV vaccine. Because we find with the RSV, when those kids do get sick, those are the ones that usually need admission to the hospital.
And may need ventilatory support.
Correct. Yeah.
And not just the kids, the moms also. It's been recommended that mothers between the ages of 32 to 36 weeks get the RSV vaccine as well. So RSV is a scary topic. You see it on TikTok all the time. Not every kid is going to be severe, and there are viral panels that you can do to determine if the child has RSV. I found that recently influenza has been rampant.
Yes.
Like I've seen a lot in office, a lot of positive influenza swabs, and mommy's asking, like, what do we do? And I'm like, honestly, we treat the symptoms unless the child becomes very, very severe and needs additional support. But even going back, one thing that popped into my head about the cough in terms of what parents can do if you don't want to give over-the-counter medication, but you want to give something else. A lot of people give honey, and honey is great, but you need to meet your age. Everything with peds is age and weight.
Yeah.
Okay, so how old and how much do you weigh? But for honey, you need to be over a year to be able to get honey. As well as like a steamy bathroom. So mommy turns on the shower, gets the bathroom nice and hot, and then turns off the hot water and goes in with baby and like sits on the I guess on the toilet or the wherever in the steamy bathroom to allow the baby to inhale the steam, or the child to inhale the steam. If they're bigger, they could have like soups, honey and lemon tea. That's what my mommy gave me, and to this day I still take it. I had some last night.
Yeah. Oh no, we definitely have done the honey and lemon tea for us and for well, not yet for Ash, but definitely for my daughter, for Scarlett. And we've definitely done the bathroom steam. Now I know, is that something where like you could put like a eucalyptus oil in the bath while that water is steaming?
Can, and it helps.
And then of course our heavy hitter, saline drops. Okay, that's Neb saline, that's saline drops. Parents don't like it, but you find that they just feel like it does nothing. But consistency with the saline,
listen,
it works.
There was like the syringes.
Yes.
You go up and
the bulb suction.
It pushes that stuff out. I can tell you.
Sucks it right out the nostril. Do not suck the baby's nose.
No.
I mean,
I know I was never gonna have that problem because I'm way too
grossed out.
Yeah, I can't do that.
But just to emphasize the importance of the saline drops. So my son was sick, and of course he's in our bed, and he had like this. He was like he was coughing so much he couldn't catch himself. So of course my husband, he wakes up. Not a medical professional, so he's frantic and he's, like do something. And it's like 2:00 in the morning. I'm like, you know what? I got this. I'm like, you hold ahead. I got that saline, and I'm not saying you do this, but I gave him a good flush. And I promise you, within 2 minutes, he was out. He was sleeping. I'm just like,
Two small babies are obligate nose breathers, which means that they only know how to breathe through their nose. So if it's clogged, they won't eat well.
Go clear it.
So we usually tell parents too, if you got like a child that has a cold, a small baby, you usually do saline pre-feeds, and this is one of those medications that we give as needed.
So 2 final questions as we wrap up. Again, going back to the idea of prevention, what are some things that parents can do to help reduce the frequency of these types of illnesses in their children?
So believe it or not, a healthy immune system. And basically what that is, rest. You can't emphasize that enough. So make sure your child has a good sleep hygiene.
Yes.
Oftentimes you have parents be like, they don't go to bed till midnight, or no. You want good sleeping habits, a healthy diet. believe it or not, your kid doesn't necessarily need those multivitamins that you buy. Unless your kid has very extremes, like, some kids with autism have food aversion, so they have very strict food diet.
Right. So
don't eat much.
Right. So the only way they can get certain things in is through
multivitamins,
supplements, things like that.
But basically, if your child has a nice, healthy, balanced diet, I emphasize that.
Balanced diet. Not the Western diet.
Not the Bohemian diet. Good sleep. Hand washing, once again, simple, but it helps and it works.
And vaccines.
Shameless plug for vaccines.
Shameless plugs for vaccines, of course. So a lot of people say, nobody's gotten it in a long time, or Susie's kid hasn't gotten the vaccine and Susie's kid is fine. And Susie's kid is protected by everybody else's kids and everybody else that took the vaccine. We call that herd immunity.
Herd immunity.
Exactly. So if you have enough Susies, you get a breakthrough.
Yeah.
And so now then you get an outbreak.
Yeah. And then that's a whole different.
When
you talk about vaccines, does that include like the flu shot?
Yes. So flu shots, yes. Which are recommended.
Yep. Kids over the age of 6 months are eligible for getting the flu vaccine. Not the live one. The live one, which is a nasal, like a spray, intranasal, starts at 2 years. But you can get the shot, from 6 months.
All right. Any final advice? So, anything, like if parents came away from this with one thing from this conversation, what should it be? So each of you get a shot at it.
So things you want to remember. So parents, you have the power, your kids. So if your child does have a fever, if your child runny nose, cough, once your child is okay, and I say it in quotes, meaning like they're still feeding, they're not in any distress in terms of breathing, it's okay to watch those ones, of course, age dependent, like we spoke earlier about, but just be empowered. Know things that you can do. So I always preach lots of fluids. It's okay if your child is picking at their food while they're sick. It's normal. Just ensure that they stay hydrated. It's when we start to get dehydrated, we run into problems. So lots of Pedialyte, coconut water, Gatorade. If your child really picky and you want to give them apple juice, dilute it.
I just say dilute.
Right? But the point is just hydration. Hydration. You want to give your antipyretics, so that's the Tylenols, the Motrins, the Calpols, whatever it is you have at home. Give it around the clock. Proper hand washing. When they blow their nose, use a tissue, not a towel. Throw it away. Wash your hands. And it helps to break the cycle.
And usually if you're going to give around the clock fever medication, that would be usually in the earlier part as they progress in their illness. And that's for very aggressive, raging fevers. Every time you check, the child hot. Every time you check, the temperature is elevated. But if you find that, the fever is waning, they're not as high as they were, the child is well, you could see them tending towards normal. You don't have to give it around the clock, for me. And then additionally, my shameless plugs. Own a thermometer, give the breast milk, and get your vaccines. And of course, a healthy, balanced diet. That's really number one. A healthy, balanced diet. A healthy mom and father is a healthy child, right? Because you can have all of the niceties of life and an unhealthy environment is still not going to produce a necessarily well child. And so, of course, hand washing, which is difficult for small children, but remembering to do hand washing, good hygiene, proper sleep, like Dr. Miller-Edgecombe stressed, and own your essentials. I feel like everybody that has a child needs to have their thermometer, fever medication, saline drops, and a pediatrician.
Shameless plug. I will also say though, in assistance with the around the clock meds, a digital assistant is very helpful. So Alexa, Google, Siri.
Yes.
Like I know when we've been in circumstances with the kids where we've had to do that, that's been very helpful. Because sometimes it's hard to remember like when exactly was that. So like you put in a reminder, you set the time, whether it's the 4 hours, 6 hours, whatever it is. And that can be very helpful in keeping on track if you're in a position where you need to do around the clock meds.
The modern day set it and forget it.
Yeah, basically. No egg timers around here. So I want to thank you both for taking time out of your busy schedules to have this conversation with us today. Before I let you go, where can our listeners find out more about you if they want to book an appointment? If they, are looking for a pediatrician, how do they get in contact with each of you?
So I'm Dr. Miller-Edgecombe. You can reach me at Healthy Kids. We are at the Cable Beach shops. So that's where Sabaro and Meza Grill is. We're in the same plaza right next to City Market.
And then for the Pediatric Place, that's where you can find me. That is Tedder Street. That's right in the Palmdale area. It's that Spectrum Health Center building next door to Darville's Packaging, or in between where Live was and Commonwealth Bank.
All right, so thanks again to both of you. I think this is going to be a very helpful conversation for the fellow parents out there that are listening. What an informative conversation. Dr. Lopez-King and Dr. Miller-Edgecombe, thank you both for sharing your expertise and breaking down what every parent needs to know about ear infections, fevers, and coughs. From understanding when to worry to practical home care tips, you've given us valuable insights that will help parents feel more confident in managing these common childhood illnesses. If you've enjoyed today's episode, be sure to subscribe to Vital Voices and share this episode with a fellow parent who might find it helpful. You can also follow us on social media for more expert health insights. Until next time, I'm Alexis Burrows. Stay informed, stay empowered, and stay well. Are you enjoying Vital Voices? Do you find our conversations educational, engaging, and inspiring? Then like, subscribe, and tap that notification bell to keep updated on new episodes and more. We'd also like to give a special thank you to today's sponsors, Oaktree Medical Center and Valor Security.
Hope Empowerment Community. The second annual Fertility Empowerment International Conference is coming to Nassau, Bahamas on April 3rd and 4th, 2025. Hi, I'm Dr. Latazia Stewart, and this year's conference will feature engaging presentations, panel conversations, and expert-led sessions on navigating fertility treatments, workplace support for employees facing fertility challenges, the intersection of faith and family and fertility, research and new innovations in reproductive health and wellness. During our inaugural event at Atlantis Resort, the impact made by our speakers and shared powerful patient stories were transformational. And this year, we're building on that success. We're also excited to partner with our new host, Doctors Hospital, for the 2025 conference. So who is this for? Fertility warriors, healthcare providers, business and civic leaders in our communities, individuals exploring fertility preservation options. This is more than a conference, it's a movement. And together, we're breaking silos, shattering silence, and empowering individuals to build their families. So, join us for the second annual Fertility Empowerment International Conference. Together, we'll continue building families, breaking barriers, and creating a future filled with hope.